thank you so much for coming out this evening on this glorious night when you could be on a deck somewhere and you're inside stuck with me. I really appreciate it. And I wanted to thank Daniel Lockwood of Wellspring for allowing me to have this room for free. Daniel couldn't be here tonight because he's at a fundraising event for Wellspring in Stratford, but he has the lovely Valerie Johnston Way, who's been helping me get everything set up here. And also, Jackie Mora, who I'm going to introduce later, is our little surprise speaker. Jackie has driven all the way from Toronto to speak to us tonight. And Jackie's going to help me queue up a couple of videos that I'm going to show. And because I've spoken to a number of women and men who couldn't make it tonight because they have early chemo tomorrow, etc., I decided to have this taped, and it's going to be put on the website and on my YouTube channel. So I brought in the handsome and debonair Steve Murphy to do that for me. Steve is amazing. Steve created and designed my entire website and shot all the videos, did all the work for it. He actually designed this and the wrap for my car, which if anybody's seen my car is really, really funky. So Steve is amazing. So I appreciate this, Steve.
Thank you.
For those of you who don't know me, my name is Annette Richard, and I am a GP in the City of London with a passionate interest in breast cancer and pain and symptom management. And I started a program a number of years ago called Face It for newly diagnosed patients. That is a program that is focused on breast cancer, anxiety reducing, community-based, empowered, individualized teaching. And some of you may know that I started a dragon boat racing team in 2000 for breast cancer survivors called Robust. So the evening is going to unfold as follows. I'm going to do 4 things. The first thing I'm going to do is show you a little video I developed, which is on YouTube, called Breast Cancer 101, first video. It's approximate, well it is, 4 minutes and 41 seconds. For those of you who have already seen it, you're going to have a boring sit-through of 4 minutes and 41 seconds. The next thing I'm going to do is 8 points on my personal views on what is and what could be in breast cancer. Then I'm going to give you the top 3 things that I learned at the Canadian Breast Cancer Symposium that I was just at this past Thursday and Friday in Toronto. I'm going to finish up with a call to action, and then I'm going to introduce our surprise speaker, Jackie Mora, who's coming from Toronto. So the first thing we're going to do is the video. Jackie. I'll start with my 8 points. Number 1, I'm going to talk about what is and what could be in breast cancer. What is the gong. Now, this is a spoiler alert for people who are about to undergo chemoradiation, but for those of you who have undergone chemoradiation, you know that at the end you're offered the opportunity to sound a gong, which is symbolic. It's kind of like the kung fu movies when you snatch the pebbles from the master's hand. But what could be is Cottage Dreams. Now, Cottage Dreams is an organization that was started by Shauna O'Neill in the Muskokas. Shauna has a fabulous cottage in the Muskokas on the lake. And one day while she was on her fabulous deck, she thought to herself, I am so blessed. Everyone should have the opportunity that I have, and she had an idea, and she approached all the other on-the-water fabulous cottage owners and started an organization called Cottage Dreams, where any woman, man, or child with any kind of cancer can, within 18 months of finishing their treatment, have one of these cottages on the lake for free for 1 week. So that's 1 week free. For those people who have children, you could choose the summer, but it's available year-round. And all you need to do is go onto the website, www.cottagedreams.org, and pull off a form that you fill out, and it will ask you what kind of cancer you have, when was your diagnosis, the types of treatment you've had, and dates, so they can slot you into the 18-month window. It can be signed by your GP, by your oncologist, or, I can sign the form. And then you have Cottage. Now, you've got what is the gong, and what could be Cottage Dreams, and I think the gong is important, symbolic, but the cottage is fabulous. And my belief is that you start with the end in mind. When I tell people about diagnoses, I start with the Cottage Dreams, because I believe you should focus on that all the way through your treatment, that positive ending. Mario Andretti, the race car driver, was interviewed, and he said the last place he ever looked when he was racing was the wall. For tightrope walkers, the last place they will ever look is down, because where your eyes go, so your body goes. So the key is, if you focus on this positive ending and just try to ignore, if possible, the pessimistic information, people, physicians that you may see, I think you'll have a better result. So that's number one. Number two, what is painful procedures? Sentinel lymph node biopsy, PICC line insertion, IV chemo, portacath insertion, nipple tattooing. Need I go on? Lots and lots of pain. And I believe as each painful procedure occurs, your anxiety ramps up, and that can really end up with post-traumatic stress disorder. And I'm aiming for post-traumatic growth. So I'm going to tell you about two things that what could be. Now the first is EMLA. This is a numbing cream, E-M as in Mary, L-A, EMLA, that is available at any pharmacy. It's approximately $11 for a 5-gram tube. For sentinel lymph node biopsies, you would apply it really quite thick to the areola, because that's where the injection will be, into the areola, the colored part around the nipple. And COPE in 2009 polled women who'd had the sentinel lymph node biopsy done without any freezing cream. And they rated it as a 10 out of 10 in pain. 1 is a little pain, 10, you blow your friggin' brains out. When they used EMLA, the pain decreased to a 4 out of 10. So a marked reduction. So everyone in their armamentarium should know about EMLA. The second thing, which was a really cool video that I was going to show you, is kind of hot off the press. In the New York Times on June 8th, a physician, Dr. Laura Esserman, who's a surgeon from the Carol Frank Buck Cancer Center in California, did a piece in the New York Times called When Pain Persists. And there's a very painful side effect of mastectomy treatment, especially for women who have mastectomy and implant reconstruction. They will get a very painful nerve pain that's felt to be caused from cutting the superficial nerves from the T4 and T5 area that come from the spine. So women will have these incredibly exquisite pain in trigger points. I have traditionally treated this with medication like Lyrica, but what Laura Esserman has done, and is easily done, your surgeon could do it, I'm getting trained to actually do it myself, is that it works for women who have a trigger point. So when the person's lying down, and in this video she demonstrated a simple procedure, you find where the trigger point is, and usually you could go along underneath the breast and people will say, yeah, that's it, and you mark that point. And there's usually 2 points, could be on either side. And she injects with a very, very fine needle a combination of a steroid, cortisone, and something called bupivacaine, which is something you get from having dental work done. And with 2 cc injection into these points, 1 cc each, the pain of this young woman that she did the injection on, who was in exquisite pain before, she was able to press all over the place. 1 injection, possibly max 3 injections. But to me, this is phenomenal, and that is what should be the new treatment for post-mastectomy pain syndrome. So for those of you who do want to check the video out, if you go on to the New York Times on Google or on Safari and look up When Pain Persists, PMPS, it's the post-mastectomy pain syndrome, you'll see the article, you can click on the instructional video, it's extremely worthwhile seeing. So that's about 3.5 minutes. That is number 2. Number 3, what is Neupogen for febrile neutropenia? Now, what is febrile neutropenia? When people go through cancer, and they go through chemo treatment for cancer, after about 7 to 10 days, the white blood cell count, the infection fighters, can drop to an all-time low. We call that the nadir. And at that point, if a person on chemo gets a fever, they must immediately go to hospital. And that's why it's important, if you're going to have chemotherapy, to have a digital thermometer and you measure your temperature, and if at that point, 7 to 10 days after you get a fever, 38 degrees Celsius or 101.4 degrees Fahrenheit, you need to go immediately to emerge, because this is a potentially life-threatening problem. Now, in the past, women and men were regularly hospitalized for several days for this procedure. You had to be very ill. And they didn't cover some of the newer treatments. But then it became such a common problem that there's the advent of medications called the granulocyte colony stimulating factors, we call them GCSFs, and they prevent the white blood cell count from dropping. Now, Neupogen, regardless of whether you have insurance coverage, is available to everyone. And it is an injection that you are taught to give yourself in your abdomen, like an insulin-dependent diabetic, one injection for 10 days after each chemo cycle. If you have 4 cycles of chemo, 4 times 10 is 40. More commonly, if you have 6 cycles of chemo, 6 times 10 is 60. Now, what could be is Neulasta. Now, in my guide, which is free on my website, www.faceitbreastcancer.com, I talk about Neulasta, which is very similar to Neupogen, and instead of 1 injection for 10 days after each cycle, it's 1 injection after each cycle. That's 4 times 1, which is 4. 4 versus 40, 6 versus 60. So right here in my guide, I suggest that people, if they're going to have chemo, call their insurance company, and they'll ask for the DIN number for Neupogen, and it's right here, 0224-9790, and they will tell you if you have coverage for Neulasta. If you don't, you go to the second program here, which is the Victory program, and I've got a telephone number. This is on my website for free, and ask them about coverage. Now, if you do not have coverage and you do have to use Neupogen, that's yet another use for the EMLA cream that you would apply a half hour to an hour before your injection every day. Put a little piece of cling wrap or saran wrap, tape it in place, and then you won't feel a thing. So that is number 3. Number 4, bear with me. I seem to have misplaced number 4. Number 4, what is chemo nausea? There are 3 kinds of nausea that you can get with chemotherapy. The one is immediate nausea, and that occurs when you're actually having chemotherapy. Delayed nausea is 2 to 3 days afterward. And the worst to treat, and the most important to avoid, is anticipatory nausea. Now, we believe this is a conditioned response. So you go for chemo, you smell the smells of the cancer center, you have the sights of the cancer center, you see the chemo nurses, who are lovely, and then you have some nausea. When you come back for your second cycle, 2 to 3 weeks later, you smell the smells, see the nurse, and throw up on the floor. You haven't even had chemo yet. You are anticipating the nausea. This is very difficult to treat. And that's why if you're given medication prior to chemo, usually ends in tron, granisetron, ondansetron, some of the new medications like the NK1 inhibitors like Emend, these in concert with steroids, you must take that to avoid anticipatory nausea, because then it's almost impossible to treat and it can last for a long time. And most women develop anticipatory nausea by the 4th cycle of their chemo. So that's what is. What could be is PMRT, Progressive Muscle Relaxation Techniques. Several studies have shown that this technique, whether you can do it from your toe to your head or your head to your toe, you do progressive tightening of your muscles and relaxing them as you go up or down your body. And this has been proven to decrease chemonausea and therefore anticipatory nausea. You can get that on the website free. You could download it to an iPod, an MP3 player, your phone, and you could listen to it in chemo. Now I'm going to give a nod to EMDR, which is a form of eye movement desensitization that I think would also be very useful in preventing this really unpleasant side effect of treatment. Number 5, getting to the home stretch. What is skin burning with radiation? Now, a lot of women will develop skin burning with radiation, and they're told to go to the over the counter and get something like lanolin, which I don't find to be very useful. or they may develop an irritation of the skin. We call it radiation dermatitis, and that is what is. What could be is my radiation cream. Now, this cream was developed by a woman in the United States who had radiation to one breast from breast cancer and had a horrible time of it. And when she got a recurrence on her other breast, she developed this cream that is mainly comprised of calendula and aloe vera. It is available at the London Ostomy and Mastectomy Boutique on Pall Mall and Adelaide. It's available online. $30 jar would do you for the entire course of radiation of 5 to 7 weeks. And I suggest it be applied before radiation, maybe a few days to a week before, and then 4 hours after each radiation treatment, which is Monday to Friday, for 5 to 7 weeks. Now, I did speak with a very close friend who is going to go through radiation for 7 weeks, and I suggested she try this, and I had her keep a video and a written journal. And the radiation technologist commented on how wonderful her skin was. So I use it all the time. It's in many formularies in the United States and in the Juravinsky Cancer Center in Hamilton, but it's not in London, Ontario, at the Cancer Center. Here in London, the general belief is that if it isn't in the New England Journal of Medicine or JAMA, it doesn't exist. So there is a small move in the right direction. They're doing now a little treatment using something called Cavalon, which is also called dimethicone. This is made by 3M. It's a chemical. It's a barrier cream, barrier film, that for some women it has been useful. I've seen some really bad results with Cavalon because it almost keeps the burning in. But you've got 3M chemical or you've got something natural going in the right direction. Number 6, what is breast reconstruction? Everybody with me? Anybody bored yet? Am I talking over here? Okay. There are 4 main ways to reconstruct the breast. The first is called the tissue expander, and what occurs is that when the breast is removed during surgery, they take a small little bag and they put it under the pectoralis muscles, this muscle right here, much as what you might have for women who've had a breast augmentation. And then for 6 weeks, approximately once a week for 6 weeks, they inject fluid into this little implant, about 100 and 150 cc's or milliliters, until the skin is slowly stretched to the level of desire of the individual. Then in day surgery, that little bag is taken out and a silicone implant is implanted. That's a tissue expander. The second is a tram flap. With a tram flap, that's called the transverse rectus abdominal muscles. You know, if you've seen people who have 6-packs, that's the rectus muscle. And they use that muscle, kind of tunneling it under to create more realistic feeling breast. That is a probably 8 to 10 hour surgery, 3 to 4 day hospital stay. End up with, you know, scars from hip to hip. And that's called the tram. The DIEP, D-I-E-P, wasn't that a battle in World War II? No. That is the deep inferior epigastric perforator surgery, which is very similar to a tram, but they don't sacrifice the rectus muscle. That's a 12 to 14 hour surgery and a 3 to 5 day hospital stay. And the fourth, which is less commonly used for women who can't or don't want a tissue expander, don't or can't have tram or DIEP, is the latissimus dorsi, where they use this muscle here. It's less commonly used. For a lot of women, if they decide not to have surgery, their choice is to pick an off-the-shelf prosthesis, where you need a specialized bra or specialized mastectomy bathing suit for your special prostheses. The Canadian or the Ontario government will cover a portion of this through the Assistive Devices Program, because this is felt to be a medical device. So if you went and got your prosthesis and a couple of bras, that would probably be somewhere around $400, and the Ontario government may give you about approximately $195. Now that is what is. Now I'm going to tell you about 2 things that what could be, and one is, once again, kind of a cool video. Irene Healy is a woman I have spoken to quite a bit in Toronto. She has a company called New Attitude. Now Irene is a medical artist who creates prostheses, and has done this for 20 years, for cancer patients who have had head and neck cancer. They may have lost an ear or a part of their nose or face to cancer treatment. And she has created these wonderful prosthetics. And now she's specializing in breast prostheses. The video is amazing in that this is a personally constructed implant that's contoured to your body. And when she shows a young woman who's very active, this can be worn in any bra. You don't need a specialized bra. And actually, if you have a form-fitting top, you don't even need a bra. It will stay in place. It fits right to the chest wall. Now, interestingly, this is not covered by the government. It's approximately $5,800. It is covered by Manulife. I've spoken with many insurance owners who tell me it's not the insurance company that we need to push, it's the employers, because there's a woman in Toronto who's in the upper echelon of her company who wanted to have this custom prosthesis and said she would not return to work unless she had it. And she obviously was at a level where they complied, so that was covered by Manulife. Interestingly enough, the TRAM, the tissue expanders, which is 3 to 4 hour surgery, back and forth, 6 weeks, day surgery for changing the implant. The TRAM, 8 to 10 hours, 3 to 4 hospital stays, and some fix-ups. The DEP, 12 to 14 hours, 3 to 5 days, and some fix-ups. This is all covered by the Canadian government. So it is odd that prostheses and off-the-shelf prostheses are not covered. So I believe in advocacy. I'm not going to take on all the employers or the insurance companies of the world, but I believe you really have to push if that's something you would like. So I'll have it up on my website, Irene Healy's video. Quite excellent. But the interesting thing, I just came from the Canadian Breast Cancer Symposium, 2 days, and the last hour of the second day was the best. And 3 women came. They're the top women in their field. One is from Ottawa, one is from Barrie, and the other one is from Toronto. And these women are oncoplastic surgeons. They are cancer general surgeons and plastic surgeons all in one. So you don't need a 2-step procedure. And some of the treatment, for instance, for women, they are doing some beautiful breast work. And of course, I don't have pictures here, but amazing work. For those women who've had lumpectomies, the current procedure, I'll talk about lumpectomies for a minute, they usually do an incision over top of the cancer and they scoop that cancer out, as it were, and they close the incision. Now, about 2 weeks later, everything's great because fluid fills that cavity. We call that a seroma. And for surgeons, a seroma is your best friend because everything looks fabulous. But when that seroma starts to dry up and the woman goes on to have radiation and that skin fixes down, you can see some really hideous results. And I've seen this in a lot of women where you've got a nipple facing every which way, and it's horrendous. And the surgery these women are doing and the training they were doing for surgeons in the audience was simply having them close that incision to not leave a space. So simple. Because they also do contralateral balancing procedures. These are all covered by the government. But sometimes they'll do a little bit of a weight because if you have a lumpectomy with radiation, sometimes the breast can shrink up to a cup size, so you want symmetry. But some of the work they have done with women to possibly avoid a mastectomy is amazing, especially for young women, women with very dense breasts, or women with very large breasts. They attack it, obviously it's cancer surgery, that's what the onco is for, but it's the closure that is so important. And they treat it almost like a breast reduction, where the breast is completely laid open. You can take great margins. How many women might have had a lumpectomy and told they didn't have clear margins and had to go back for more surgery? In this way, with a lumpectomy, they can get great margins, fabulous closure, and they can do the nipple reconstruction at the same time. Because most women, if you have any of these tissue expanders, trams, DEPs, lat dorsi flaps, you know you don't have a nipple areola complex. That has to be done at a later time, either to create a nipple and then at a later time to even do tattooing. Or you could avoid that and you could go straight to nipple tattooing. But I am now going to, in select women, strongly suggest they see either Angel Arnaud, who's in Ottawa, Renee Hanrahan in Hamilton, in Barrie, or Adina Shear in Toronto. Just amazing women. I think that is going to be the major way of the future for breast cancer treatment. Number 7, what is trying to get into your GP to talk about how freaked out you are about your diagnosis. I don't know how hard anybody's found that to be. And most GPs, you know, they're not with you when you're scared at night. You only have your companion being maybe the internet. So what could be is something called guest links, and that is a program through the government I've been accepted for through a pilot program, and I believe hope is the way of the future. And that allows me to talk to breast cancer patients in the comfort of their own home via computer. It's similar to the concept of Skype, but it's not Skype, because the government did not feel Skype was secure enough in its infinite wisdom, so it took 2 years. I'm really excited about it, and obviously there may be some kinks, but especially for women who live outside the city or who are in different cities, I've gotten approved for all over Toronto, all over Ontario. My problem is trying to break into all these markets and get away from what I call the teams. I'm a solo GP in the city, and most GPs are in teams. And we call them family health teams, family health groups, family health organizations, fits, figs, or foes. I just refer to them as fee-fi, fo-fum. And these groups are paid differently than solo GPs, and very lucrative. I mean, not to say there isn't altruism involved, but usually it's not altruism. They join these groups because it's incredibly lucrative. Here's the problem. There's a contractual obligation on the part of the patient who signs up to these teams to stay within the team. If you choose to go outside the team, as I've had 2 women recently tell me, and one was in a palliative situation. Unfortunately, she died, which is very sad. She had a doctor of about 20 years, and both these women came to see me through word of mouth. And both of them received phone calls from their doctors saying, were you aware that, I am aware that you saw Annette Richard on this, and this occasion. Are you aware that this is kind of costing me financially? Now, of course, my first thing, if somebody did that to me, would be Foxtrot Opera. And then my second thing would be a smart call to the college. But for the palliative patient, she was actually made by her 20-year-plus GP to choose. So, sadly, and I'm not even looking for permanent patients. I'm looking to help people through the process. But, you know, she chose me, and it's a problem because not only, this is one of the reasons why we're having a lot more emerge visits, is that if a patient cannot be seen by the team, they are told to go to emerge, not a walk-in, not urgent care, even though it may be walk-in or urgent care amenable, but to go to emerge, because if they go to emerge, the doctor is not financially dinged. So this is a big cost to our system, lucrative for the physicians, and then stands in the way of emerge when, you know, maybe the rest of us really need emerge. So I believe there's a contractual obligation on the part of the patient when you sign the registry, but I believe that the Hippocratic Oath that we all swore to in medical school, that's ancient, but its basic tenet is the physician must renounce self-interest in the treatment of the patient. And I believe that's more important. So I think that's why I'm going to say at the end, if people don't feel comfortable going outside the team, at least I'd love people to know about the website where I have all kinds of free things for them. So I'm coming to my last thought, which is, what is the binder? Now, I'm not going to cast aspersions on the binder, because I know I have people here that are working to make the binder fabulous. But if you had seen my little cartoon at the beginning, you'd realize that there are women that have local treatment first, which could be lumpectomy, mastectomy, or radiation, followed possibly by something systemic like chemotherapy or pills, or they may have chemotherapy first. If you go to the cancer center, you get the binder. But if you have surgery first, or you don't go to the cancer center, you don't get the binder, you don't get any information. And it's chock-a-block with information, but it doesn't have cottage dreams, Neulasta, Emla, Mepiform, Victory Program. It doesn't have those things in it. So, I mean, I'd love to be in the binder, but I'm not in the binder. So, my thing of what could be is Face It, which is www.faceitbreastcancer.com, because you can go to this great website that Steve created, and you can see 13 free videos. You can get this free guide. You can have access to post-mastectomy pillows and drain bags and cool bracelet and relaxation CD and cottage dreams and Emla and Neupogen, Neulasta, the whole 9 yards. So that's those are my kind of points on, those are my personal views on my 8 points. I'm going to do the second last thing. I'm just going to give you a quickie of the 3 things I gleaned from the Canadian Breast Cancer Symposium. All cancer is genetic. However, only a minority of cancer is inherited. Big difference. We start as one cell, and at 9 months, when we're at 9 months of age, we are at 1 to 5 trillion cells. The normal adult has 50 to 100 trillion cells in its body. Our bone marrow, that makes white blood cells, amongst other things, makes 17 billion white blood cells per day. If you have an infection, it can go up to 50 billion. So I mean, lots of room for error. And cells, normal cells, are very strictly regulated in how they grow and develop. First of all, they are only stimulated to grow by growth factors. They, if damaged, there's a molecular brake put on them until they're repaired. If they're not able to be repaired, they're forced to commit cellular suicide. There's only a limited number of times they can divide. They have to stay put, and they need a blood supply to grow. But cancer cells are amazing. They're self-sufficient. They don't need to be told what to do. Their accelerator pedal is stuck in the on position. They've got no brakes. They are invisible to the immune system. It's like on Star Trek, they have a cloaking device. They can divide as many times as they want. They're immortal, like vampires. They tell the body to give them a blood supply, and they can spread as they wish. So the new way of treating cancer is going to be ultimately moving toward, and it is moving toward, a very individualized look, looking at biomarkers, more of genome factors. And at each level of the cell, as it divides, where it takes a rest and gets some stuff and takes a rest, it does some more stuff, there are stop points, checkpoints, and a lot of drugs are being targeted at these checkpoint areas. But if we remember when we were kids and we were in a long car ride and we were like, are we there yet? Are we there yet? Are we there yet? Well, we're not there yet, but we are much closer. The interesting thing for a lot of women who may be triple negative is that there are a lot of new treatments. There are some new vaccines coming. There are new drugs called the PARP inhibitors. There is a new way of looking that cancer down the road may not even just be breast cancer, it may just be cancer is cancer. And they're using a new medication called pembrolizumab for melanoma patients in triple negative patients. For women who are HER2 new, this is an extra protein on the cancer that makes it a little bit more aggressive. They would be offered treatment like Herceptin, trastuzumab. Now there's a couple of studies looking at something called Kadcycla, which is Herceptin with a kick. So the last thing that I learned was about the Oncotype DCIS test. For those women who have an early cancer, DCIS, they're typically treated with surgery, and that's that. But this new test, called the Oncotype DCIS, there's one for invasive cancer, the Oncotype DX, to see if you need chemo. The Oncotype DCIS test will look at women, and it's a 21 gene test that looks at a score. If it's less than 18, the chance of recurrence is low. If your score is greater than 21, that might mean, even though you have a DCIS, you might benefit from a sentinel lymph node biopsy and potentially further treatment, because it says your risk of having a recurrence of DCIS or a second invasive cancer is higher. Interestingly enough, covered by the government, both tests, the use of the Oncotype DCIS test in London is the lowest in the province. Need I say more? I'm going to leave you now with a call to action. So if you know of any women or men who have been diagnosed with cancer, at least if they don't want to see me, which I understand, I'd love if you could pass on the website so they have access to all sorts of free things. And I want to thank you for your time, but I've got a surprise. But thank you for listening to me. Now, this is my surprise. I've been speaking a lot with Canadian Breast Cancer Foundations, and one woman in Toronto, Kelly Zeiger, connected me with Jackie Mora, who's driven all the way from Toronto to speak to you. Jackie did a lot of work with Canadian Breast Cancer Foundation and is doing work, and then ironically herself was diagnosed, and she's doing a lot of speaking and wanted to come down and speak to you. So, everyone, Jackie Mora, Jackie, everyone.
Thank you. That was amazing. I wish before my diagnosis, I wish I had the opportunity to meet somebody like yourself, go on your website, and that's what's been so amazing about it, being able to share. Is everyone sorry, where do I stand? Is everyone being diagnosed, or are you already in treatment? So some are in treatment. So, you know, thank you for your warm introduction, but I'm an interior designer, which is kind of strange. And I speak right across Canada, and I'm never nervous. Tonight's the first night that I'm talking to women like myself who've been diagnosed with breast cancer. So I'm a little nervous, which I normally am not, but I'm way out of my comfort zone. But the reason I came is just to share some positivity with you, and I went through my treatment, and just to give you some tips. I certainly, by all means, don't have it all together. I don't know, you know, all the things that you're going through. Everybody's at different stages. But I think through my journey, I had my surgery in January. So I was diagnosed with DCIS at stage 0, and I had a mastectomy on January 6th and immediate reconstruction. Okay, this one's the real one, this one's the fake. I know, because you're wondering, right? Because I do too. And I wore something tonight so that at least you could see. I mean, what I wanted to do was just say, you know, I have been through the journey, and what is the best thing that has been for me is to stay positive. You know, when I found out about it, you're gonna feel, right? I want you to feel. We are supposed to feel. I was going along my merry way. I didn't have any you know, predisposed for this. I didn't have any hereditary. I had a lump in my breast a couple years ago, and my doctor sent me for just it was a biopsy, and then they removed the lump. It was nothing. And she said when they were in there and they got the reports back, they said, oh, you've got very dense breast tissues. So 2 years ago, she said to me, you know what, I've been looking at all this stuff when we do the physicals, why don't you start going? I'm 44, so I had no business getting this, right? Like we all don't, right? And I went, and they told me right away, you've got to get a biopsy, you've got to go, it's got to go surgery, immediate reconstruction. And so I was traveling, I had all these plans to do all these things, and it turned my world upside down. So I went from, like, you know, and these are some of the feelings. I want you to feel them, and I want you to embrace them and be able to share with them, but then you've got to put them in their place, because they will stop you in your tracks and keep you in fear if you don't, you know, kind of grip with them. So for me, it was very difficult to like, why is this happening? For me, I'm a control freak. If you know me, I kept to control everything. And that has been one of my greatest lessons. I can tell you this, you will get something good out of this. I know it sounds horrific, right? It sounds like, shut up, what are you talking about? I'm gonna get something good out of this? You are gonna get something good out of this. You can learn something amazing about yourself. Something good is gonna come in the end. And I started to change my attitude. And I started to say, you know what, instead of looking at it as like a problem or the circumstance, I looked at it as like, how lucky I am to find out that I can now start treatment. Because the one great thing about breast cancer is that it's very treatable. And it's 1 in 9. You know, I'm unlucky. No, it's 1 in 9. We have a lot more people in our lives showing up with breast cancer, and whether it's hereditary or not. And so for me, it was just starting to, how do I then, I'm very positive, but I've never had something personally affect me. For years I've been talking about design and working with different charities, and I love to do that. And you know, one of my dreams has been to be able to speak to women, or to be able to just do more in terms of, the design is like the superficial stuff. It's stuff we need and all this stuff, but it's not the real core stuff of, you know, for me, this talk, the drive here today, was, this is just, for me, something to be able to share with you, and to be able to speak to all the women that I've been speaking to with breast cancer throughout the shows. It's amazing when you start to connect and share how you realize you're not alone. And we're all going through stuff. So I'm getting all off track, but my basic thought was, how do I turn this into a positive? How do I, and so we surrounded myself with my husband, my son, all of my friends. So we made a couple of rules. Nobody's going to talk negative. Nobody's going to let me go into the pity party. And you know, some days I wanted to kill my husband, because we all do. Sorry, man. Because I was like, okay, I need to vent. You know, and then he would stop me and say, but you know, you're so lucky, and this is treatable, and this is great. And I'd be like, but no, I just need to be in my pity party. Like, why me? And you know, and so we made a new pact, a new rule in the house that we're not going to go down that route. So when you find yourself in pain, when you find yourself, you know, with maybe not the greatest news, or you've got to go for another treatment, you've got to say, you know what, I'm still a lucky girl. This is treatable. I can do this. I need to be positive. Surround yourself with positive people. If anybody's going to go, oh, sorry, I'm so sorry. No, say, I'm glad that I found out. I'm actually lucky that I can start treatment. I can start going along the way. The other big thing for me that has held me completely together, whether you call it God, whether you call it faith, whether you call it the universe, is having something to trust and believe, knowing that everything will work out for your benefit, for your good. And it doesn't seem like that, but if you try and think back to some situations in the past that have been negative for you, I always would say to my friends, you know, you'll bless it one day. And myself, when I come out of something difficult, you'll bless it one day. And when you're going through it, I'm not the first one standing up to bless it. That's for sure. But as you go along the process, you know, your faith is so important. Whatever you believe in, it's the time to tap into it. It's the thing that's going to carry you through, that's going to carry you through the distance. I got this beautiful quote from Ilana Van Zandt. She's a life coach with Oprah. And this is what stuck with me throughout my 6-week journey. And I had the surgery and immediate reconstruction. So I was in bed and I was home for 6 weeks because of all the suturing and stuff of the implant. It's not like having the inflator. It's quite, the healing is a little bit more intense, but all good. Prayer is asking for rain. Faith is carrying an umbrella. Faith is the inner sense of knowing that with divine order working on your side, all things will come together for your good. Faith is knowing that there's a divine plan and purpose for everything in life. So for me then, I started to ask myself, so what is this purpose? And remember I mentioned the control freak thing? While I was there 6 weeks with a lot of time, Annette talked about the nerve piece. I was taking gabapentin. I had a lot of that. So, and now I've just started dragon boating in Toronto. Oh, it's amazing what it's been doing for my arms. And, you know, of course I was afraid to go out and start to do something because my surgery was January, but I'm doing great. And it's like I'm embracing everything. Anytime that something comes my way and I feel no, I must do it. I say yes. So I had all this, you know, bit of nerve damage, and I was going through a little bit of pain. But, you know, you're pressing into it every day. And I said to myself, well, you know, here I am. I couldn't watch TV because the gabapentin made me fluky. And I don't really watch TV anyways, and I couldn't read as much. So some of the things I did was, you know, I started to journal. And I would highly recommend it throughout your journey. When you journal, it gives you a voice. And it's like, you know what, and Annette talked about being able to call somebody in the privacy of their own home and have you share. When you journal your feelings, no matter how dark they are, no matter how deep they are, no matter how negative you are, what you do is you let them go. You let them go and you give them away. So by journaling, it's very painful to write it. I mean, I would be writing and it was like, I can't see anything because of tears. But it would be like a purging for me. And the other thing I kept was a gratitude journal every single day. So this was the one thing, because, you know, it was a shock for me, and then I canceled my whole spring across the country. You know, everything I thought was important was now totally not important, just getting better. So I started to keep a journal, a gratitude journal. And, you know, it started with little things like I can see out the window and I can see the snowflakes and I can look at them. You know, and then of course it started with like my family, the big things. But what you're going to do is that's just going to help take the focus off all of this that you are feeling all of this that you are going through and wanting to ask yourself. I did feel, when at the beginning I asked myself, why me? You know, I questioned God, but I came back full circle to, I know and I trust that this is a part of my journey. When my GP told me, I said, this is part of my journey. And so one of the things is when I was laying there in bed a lot, I asked, what do I need to learn? Letting go of control. The biggest lesson that I've gotten out of this journey, and it's been tremendous on my life, tremendous on not worrying. You know, when we carry stuff with us, we take it around and then we purge it around and then we take it again and it doesn't go away. And the biggest lesson I've learned is I'm really not in control of anything. This is what breast cancer has taught me, but that's a good thing because I can trust. I can trust in the divine, I can trust in a higher power, I can trust in something bigger than myself. And that's where faith really comes into play. So if you can gratitude journal, if you can, you know, whether it's a Bible, whether it's something good, you know, just positive words, whether it's, you know, lots of books like Simple Abundance, anything that's going to help you in every day when you get up, look at the positive and have everybody around you remind you of how beautiful you are, how positive this is, what you have in life. Don't look at the lack when you're going through this. It is very easy when you're lying there, when you're afraid, when you've got treatments to go to and you have no idea. And a lot of it is fear. All of it is fear, I think. You know, because, and the more you play it out in your head and you start to go into your head, it becomes this big monster when it's really quite manageable. It doesn't seem like it, but it is. And I can tell you, it's like having gone through it now. I'm 6 months, I'm going for my checkups with the pathology, and I'm going to see, I am taking tamoxifen as well now for 5 years, so it's throwing me into menopause, so that's why I had to put the sweater on. I've got like the hot and the cold. I'm loving it. I'm no longer cold in the winter. It's fantastic, you know? And it's like Annette said, if you choose to embrace positive, you choose to see the positive, see that you're strong, you can get through this, and if you can use your story and use your life, how wonderful will that be at the end of this? If you can serve. And that's why I'm here, because serving is the most important. And if I can come here and just share my opinion, and like I said, I don't know it all, I certainly don't. But if I can give you some hope that it's going to be awesome, it's going to be a good journey, you're going to get through it, thank God it's treatable, and if you look for whatever little glimpse in the everyday that is there, you know, then I've done something good to give back. And the funny thing is, my dream was always to talk to women and do something a little bit more than, you know, just my work, just my career. And it's funny how breast cancer has given me that. Now I'm working with Breast Cancer Foundation. Out of this horrible thing, I'm now going towards a purpose and one of my life dreams of being able to speak to people about something more meaningful and something that I can only speak to you because I've gone through it. I couldn't be standing here today without any of this and talking to you at all. Working with Breast Cancer Foundation and speaking to other women, just saying, you know, taking a look and checking for the lumps. I mean, from the very beginning to when you get a mammogram or when you get a biopsy, just putting that out there. People are starting to, all the girls on my hockey team, I played hockey before my surgery, just started back up again. And the girls on my team, she was putting off going for her mammogram. Because she says, I just don't want to know. And I said, you know what, you're better off knowing. I've met people at stage 3 and I've met people at stage 4, and they're totally treatable. It's a longer journey and you may have a longer process, but you're going to be fine. So I hope that, and you can ask me any questions if anybody wants to see. I'm more than happy to show you my lovely scar. It is beautiful. It is a reminder to me to slow down. It is a reminder to me to trust and not worry about the stuff that I used to worry about every single day. And most of all, trust in the divine and let go of the control. Because as soon as I do that, I can breathe. I'm so much happier. I'm so much lighter. If you get a chance to meditate as well too, which I've started to do now because of all this process, it's amazing. If you can meditate and get some silence, the peace you will feel. And you know, the last thing I said before I went into surgery was, thank you, God, this is a gift. I don't know it, but it is a gift. And that's how I choose to embrace it. So stay positive, Don't let anybody talk any negative stuff. There was a lady with her daughter who had cancer, a different type of cancer, and that's where I heard about this positive thing. And she said nobody could set foot through the doors if they didn't have a good thing to say, and they didn't want to, you know, no pity parties. You're going to be great. You're going to be awesome. You're going to get through this because you have what it takes. So stay positive, okay? And if you want to be in touch with me or talk to me or anything, I'll leave you my information through Annette, but you can just Google Jackie Mora. I'm online, it'll show up Jackie Mora Interiors, but you can just email me. But I know it's a long journey, but it's going to be a good journey. And try to look for the blessings, even though you don't think they're there, because you're going to get it. And if you're conscious of asking for it like I would, my prayer would always be like, what do I need to learn from this? What do I need to learn from this before I go to bed and when I woke up at night? And then I finally got the answers, but you got to be looking for it. Because if you get caught up in being negative, if you get caught up in focusing on the wrong things or focusing on, you know, just, oh, poor me, the whole thing, why did this happen? It did, you know? It's like you didn't choose it, but for me, it's like predestined for me that it was going to happen to me. And I'm just choosing now to pull out the good stuff from it. Thank you for your time.